All right, we're going to go ahead and get started this afternoon. I want to thank everybody for joining us. I know that the folks continuing to join, but I want to be sure that Dr. Benjamins and De Maio get a chance to really spend some time with us this morning on this topic: unequal cities, structural racism, and the death gap in America's largest cities. The Institute of Medicine of Chicago is an independent organization of distinguished leaders in the field, and we're celebrating our 8th convening of the State of the Health of Chicago. Before we begin today, I would love to share with you a few upcoming events. On October 8th, one second here. On October 8th, we've got Dr. Melissa Simon, who's going to be talking with us about her work in tackling maternal health equity to achieve maternal health justice in Illinois. That's on October the 8th. On November the 12th, Dr. Melanie Dreyer will lead a session about cannabis and everything you need to know and be pain-free with CBD. In early December, the Institute of Medicine is pleased to have former CMS Administrator Andy Slavitt, who will talk about his new book, Preventable: The Inside Story of How Leadership Failures, Politics, and Selfishness Doom the U.S. Coronavirus Response. He's worked in the Biden White House on this topic. We look forward to hearing about his experiences and his observations and thoughts. We have other program planning in the works. If you're a fellow and you have ideas, please share with us any thoughts that you have. In April, we'll be doing a session in combination with the Rosalind Franklin University School of Medicine and Science about the intersectionality of education and community engagement. So we're looking forward to the spring as well. So let's get started and talking about our excellent session today. I'm looking forward to introducing the authors to you, Dr. Benjamin, Dr. Maureen Benjamins, and Dr. Fernando De Maio. They will talk about their research in their new book, Unequal Cities, Structural Racism and the Death Gap in America's Largest Cities. It was just released this week. Chicago has had worsening Black and white mortality in the ratio in the past 10 years. We can do better, we must. There are signs in other parts of the US where things are actually moving in the right direction. So our speakers are going to share some of their research, their data, some of their insights from that data. Dr. Maureen Benjamin is a senior research fellow at the Sinai Urban Health Institute. Her research pertains to health inequities and the influence of social factors on these inequities. She's led several initiatives to study health equity nationally and in Chicago, including the very famous Sinai Community Health Survey 2.0. She worked with the late, great Dr. Stephen, who we missed terribly, and work on the Unequal Cities projects, which examines racial inequities overall and cause-specific mortality across the biggest cities in the US. She's a co-editor of Urban Health, Combating Disparities with Local Data. Dr. Benjamins developed and directs the Sinai Population Health Institute, which is an interprofessional institute focusing on health equity and the social determinants of health. Dr. Fernando De Maio, welcome. Dr. Fernando De Maio is a director of research and data use at the Center for Health Equity at the American Medical Association. He's also a professor of sociology at DePaul, where he teaches social epidemiology and data analysis. His research and teaching interests lie primarily within medical sociology and social epidemiology, with a focus on the concept of structural violence and the social determinants of health. His work has been guided by the notion of radical statistics, the idea that statistical analysis can be used not just to describe the world, but to change it. Dr. De Maio is a fellow of the IOMC. The objectives of today's session, today's critical session is important to all of us. By attending this session, you will discover the 10-year gap in life expectancy between our healthiest and unhealthiest big cities, compare new previously unavailable data on life expectancy, mortality from leading causes of death, and related Black-white inequities for the country's 30 biggest cities, identify the characteristics of cities, including the levels of income inequality and racial segregation that impact overall health and Black-white inequities. We value your time today and being attuned to today's learning objectives, and trust you will be able to take away ideas to guide you and share with your colleagues. We want you to be able to associate, identify, and relate to the bias and factors occurring and think about how you can be part of making systemic changes in the right direction. This program is accredited by Rush University and affiliated associations. You will be able to obtain your continuing credit at the end of the program. Our speakers have completed their conflict of interest financial disclosures, and their information is on file. I would like to thank our sponsors: Blue Cross Blue Shield of Illinois, Northwestern Medicine, Rosalind Franklin University, University of Chicago Medicine, the Portis Foundation, the Michael Reese Research and Education Foundation, the Washington Square Health Foundation, the Hectone Institute, Complete Care, Aunt Martha's Health and Wellness, Care Advisors, and Golden Square. Thank you so much to our sponsors. This is the first book to specifically examine racial health disparities and inequities within and across U.S. cities. Unequal Cities offers a social justice framework for addressing the newly identified inequities, as well as specific case studies to help public health advocates, civic leaders, and other stakeholders envision the steps needed to improve their city's current health outcomes and achieve racial equity. This book serves as a powerful call to action for health equity advocates and city leaders alike. The authors have stated, "We are here to change the landscape, not to do more studies." Amen. It's about people. It's important for us to keep this in mind today and tomorrow as we go on with our work. I'd like to turn the session over to Dr. Maureen Benjamins and Dr. Fernando De Maio. Welcome to the IOMC, and thank you for kicking off our fall programming. We're so happy to have you here today.
Hi, so I'm Maureen Benjamins. As she said, I'll be starting off and then turn it over to Fernando. Before we started, we wanted to thank all the people that have been instrumental in this line of work. It's a big, long line of studies that I'll talk about. In particular, we wanted to call out Nazia Syed and Abigail Silva, two fellow epidemiologists who were critical to all of the analysis that I'll show today. I'll talk more about Steve, and these were the rest of our SOHOC colleagues who conducted some of the early studies that led to this work, our collaborators and co-authors to some of the book chapters, those who reviewed or consulted on different pieces of the research, and our publishing team at Hopkins Press. To give you an idea of how we will go about today's session, first we're going to talk about the background and the history of this line of work, and then I'll dive right into the main findings. After that, I'll turn it over to Fernando, who will talk more about how we can start to understand the differences between cities and the differences between the racial groups, and then end with that important step of how we can move from this data into actual steps in action at the city level. So I wanted to start with this picture. This is from a magazine cover. This is Steve Whitman, for those of you who don't remember him or didn't have the chance to know him. He was the founding director of the Sinai Urban Health Institute that we call SUI, and he was really the heart and soul of all of our efforts to address inequities. He was passionate about talking about equity and talking about racism as the fundamental cause behind these differences. You can see a quote there from the magazine where it said, "We've arranged things so in this country so that the darker your skin, the shorter your life will be." And he always took us back to that point to remember these aren't genetic differences or biologic differences. These are things that we arrange our society allowed to happen by how we structured our policies and our systems and our institutions. So this is the graph he's holding. You don't need to look at the numbers in particular, but what was really interesting, this is our breast cancer mortality rate study. The black and white rates are there, and you can see they were really close and they kind of traded places for quite a while. And then sometime in the mid to late 90s, they began to diverge. And at the time of this study that he did with Jocelyn Hirschman and Dr. David Ansell, who many of you know, at the time, the black rate was almost twice the white rate. And this was really concerning. And they started to think, is this happening in other cities as well? What's going on in New York? What can explain this? So that's what led to our first study where we compared city level rates. It got a lot of attention, as you can see, from the popular press and in academic journals, of course. But what was really important to us was that it led to real changes. So then Steve and David co-founded the Metropolitan Chicago Breast Cancer Task Force, which of course has led to many really important policy changes related to quality metrics and funding for mammography in our city. It also inspired changes in Memphis, another city that had big racial gaps, and in some California cities as well. So what this really identified was there was a gap in our research. So we know that there's been differences in Black and white death rates for as long as we've kept data, or race-specific data, so back to the 1800s, and we continue to document these differences at the national level and the state level and the county level, but there's this gap that mortality data, and particularly data on inequities and mortality, is not available at the city level. So over the last 10 years or so, at SUI, we've been putting out study after study. It kind of grew organically. So we started with cancer, breast cancer, and then lung cancer, and we went to heart disease and diabetes. Most recently, one of our partners, Dan Schober at DePaul, led the team in doing a homicide and suicide papers. But it came down to, we were seeing patterns, but it was hard to compare. They were from different years of data. It was hard to see if the same cities were faring well across all the outcomes or not. So this is why we came to the conclusion we had to write a book. We needed more space to look at this systematically. So our book is answering these questions. So at the basic level, what's going on with death rates across the biggest cities and life expectancy and other measures of mortality? And then importantly, how do the racial differences in mortality vary across cities? So that gap between the white and Black mortality rates, is that the same across cities? And then how can we start thinking empirically about the city level characteristics that might be associated with mortality rates and with the racial gap in rates? And then finally, we're really interested in how the rates and the gaps change over time. And that's something we couldn't fit into the book, but we are working on as we put out papers now. So the book's organized. At first, we just wanted to put out this data, and then we realized we really need to bookend it. We need to help people understand what they're seeing and why. So the beginning part of the book is the history and the theoretical foundations of health disparities. Fernando will talk more about the theory next. And then we have all the data. And then the final part of our book is that translating data into action. So that's where we talk about what cities can do once they see what's going on with their data. So here are the 30 most populous cities. The size of the dot reflects the size of the population. You can see Chicago there is the third biggest city in the US. I won't talk a ton about the methods, but we're happy to answer any questions. Also, I noticed at least Nazia is on the call. So if you have questions, you can put them in the chat and one of us will hopefully get to those questions. We use the National Vital Statistics System, the death certificate data that gets compiled at the national level for the death data. And then we use the American Community Surveys for the population data. The book used 2013 to 17 data, which was the most recent we had at that time. We look at mortality in many, many ways. So we look at all-cause mortality or death from any cause. We calculate life expectancy and premature mortality, which is death before the age of 75. Then we look at cause-specific rates as well. For equity, of course, best practices are to measure racial inequities in different ways. So we look at the relative difference using rate ratios, then we look at the absolute difference using rate differences, and then we also calculate excess deaths, which I'll talk more about. Just so you know the scope of this endeavor, which is really a credit to Nazia, there were 13.5 million deaths in the US during this time period. The mortality rates, we calculated about 1,500 of them. So for each of the mortality outcomes, we calculated the total and the non-Hispanic Black and non-Hispanic white rates. This is a good time to mention that we, of course, know that it's really important to look at more racial and ethnic groups beyond just Black and white. We chose to focus on the Black and white rates because The Black mortality rates are noticeably worse than the white rates or other racial and ethnic groups in our country. So we started there. It's also related to the numbers. When you're looking at some of the other racial and ethnic groups, there's simply not enough deaths in all the cities, particularly for the specific causes of death. So we hope to do more in the future, but right now we'll focus on the Black and white difference. And then 1,200 equity outcomes. I'd like to go back to Steve's words, which I think about often, and he said this. He said, you know, it's one thing to talk about data, but I think maybe it's possible to get lost in the data. Remember that this is literally a matter of life and death. And he would say this. SUI is located in Mount Sinai Hospital in North Lawndale. And he would say, remember, look out the window in his office. He'd say, that's who we're talking about when we're talking about excess Black deaths. It's our friends, it's our neighbors, it's our family. It's the people we're looking at right now. Okay, so I'll jump into the findings. We're going to start with life expectancy. That's one that everybody has a good grasp on. It's easier than some of the mortality rates to understand. So in the US during this time period, the life expectancy in the US was 78.6 years. When you look at it across cities, you see this big range. So up at the top, the San Francisco and San Jose in blue, the life expectancy for a baby born in those cities during this time period was about 83 years. All the way down to the bottom, you see a baby born in Baltimore at this time period, life expectancy was only 73 years. So that's where we have this 10-year difference in our biggest cities. It's helpful now to look at the difference between the Black and white life expectancy. So at the very top, just to help orient you to this figure, the green balls, that's like Black life expectancy, the blue is white. That bar in the middle shows the absolute difference. So in the US, the life expectancy for a Black child would be 74.3. And then you can see the white life expectancy was considerably bigger. That was 78.5. So about a 4-year difference between Black and white populations in the US. The cities now are below that, and we sorted them by the size of the bar. So in other words, at the top, Washington, DC, that had the biggest gap between the Black and white life expectancy. And Washington, DC, that is a 12-year difference. If you just look at the green circles, you can see the shortest life expectancy for the Black population was seen in Houston, where life expectancy was only 70 years. On the other hand, in New York City, the life expectancy for the Black population was 78.7. So it's slightly higher than the overall life expectancy in our country. So a big range there. In terms of white life expectancy, it ranged. In Baltimore, it was, I think, about 76. And then it went all the way up to Washington, DC, where the white life expectancy was 85.5 years. You can see our own city of Chicago was very close to the top. Only 3 cities had a bigger absolute difference. And in Chicago, there's an 8-year difference between a Black baby born during this time period and a white baby. So one way we'd like to combine those 2 measures. So on the vertical axis, we have the overall measure of population health. So the overall life expectancy. So you can see at the top, the San Jose and San Francisco that had the highest, and at the bottom, Baltimore. As you move from left to right, that's the level of inequity. So on the far left, that's where there was more parity between the races. They were fairly even. On the right, that was where you had the most differences, like Washington, DC, with that 12-year difference between the Black and white life expectancy. So you can see in the upper left quadrant, these are the cities that were performing the best. So they had above the US average life expectancy and below the level of inequity seen for the US. So New York, Boston, El Paso, they tend to come out in this best performing category. On the other hand, you'll notice Chicago and many other cities in the worst performing category. So these are cities that have below the US life expectancy and more than that 4-year difference. So more inequity than you see in the country as a whole. This is really important, even for the cities in the off quadrants that aren't highlighted, because as you probably know, if you're trying to implement a policy change or a new program or intervention, the interventions or policies that are aimed at improving overall population health are different than those that are trying to improve the health of a specific group. And often when you do something more generally to improve everybody's health, that can often lead to widening disparities. That happens, you see it with when new medical technologies come out. You think it'll help everybody, but it doesn't really, right? It helps the people that have more access and more opportunities, and then that widens the gap. So it's really important for cities to know where they stand here. Okay, so this is the relative measure of inequities. This is the all-cause mortality Black-white rate ratio. So in other words, it's the Black mortality rate divided by the white mortality rate. You see Washington, D.C. again stands out as having the highest inequity. If you look just at the United States, you can see the rate ratio is 1.23, and how you would interpret that is the Black rate is 1.23 times higher than the white rate for our country. Or you could say the Black rate is 23% higher than the white rate. You can see all the way down at the bottom, El Paso actually has a higher life expectancy for the Black population than the white population. It's very small, but they do have kind of that reverse gap. Several of the cities at the bottom, Boston, Louisville, Columbus, have a very small rate ratio. Okay, then I want to talk about the final measure of inequity, which is annual excess Black deaths. So this is the additional Black deaths that occur each year because the Black mortality rate is higher than the white rate. So you calculate this by calculating what the number of deaths that would occur if the Black population had the white mortality rate, and then you subtract it. So this is a function of both that size of the gap between the white and Black populations rate ratio or rates and the size of your Black population. So you can see here, Chicago really stands out. Chicago and New York, they both have big Black populations. And as you saw, Chicago has a fairly substantial gap between the death rates for the Black and white population. So this is really, it's tragic, right? There's no other way to describe it. There's over 3,000 of our own residents dying each year because our Black and white rates are not the same. What is perhaps even sadder is this is a headline from the Chicago Sun-Times over 10 years ago. We did the same calculation over a decade ago, and we found that the gap was 3,200. So the gap is now bigger. And in fact, we just published a paper where, with more recent data, where it's grown to 3,800 excess Black deaths each year. And then finally, I want to show you just a few of the cause-specific mortality examples. I think we felt like it was really important to get cause-specific because life expectancy, it's really hard to move, right? It has a really long time. There's a lag, right? The things that affect your life expectancy happen across the life course, and a lot affects it. When you look at cause-specific mortality, it's a little easier to think of policy changes or programming that might influence that particular outcome. So we looked at the leading causes. Here are the 10 leading causes. And then we looked at 3 additional causes of death that we felt like had larger equity issues. And in the case of opioids, some really interesting changes recently. So I'll just give you a few examples. Here's the diabetes mortality rate. One reason this is interesting is El Paso, as I mentioned, often showed up as having pretty good mortality outcomes, but that's not across the board. So here for diabetes, they had the highest diabetes mortality rate, significantly higher than the United States as a whole. And some cities like San Francisco had much lower rates. This is from our book, but also a more recent paper by Joanna Buscemi from DePaul. Chicago is there just slightly above the US mortality rate. If you look at the Black-white differences in diabetes mortality, you can see Washington, DC has a huge difference. In the US, the Black diabetes mortality rate is 2.2 times higher than the white mortality rate, but this varies significantly across cities. In some cities like Detroit and El Paso, that's only 1.5 times. Chicago is right there with the US. Of course, we all know that we have a huge homicide problem in our city. You can see here that Baltimore, Detroit, and Memphis actually have a bigger problem with it in terms of the rate. So the homicide mortality rates are the highest in those cities. In the US, it's only 5.7 deaths per 100,000 population, but way higher in those three cities. And what's really interesting is the difference between the Black and white rates varies so much across cities. So you can see in Chicago, the rate ratio is 26.4. Fellow researchers will know you rarely see rate ratios this high, right? That is a huge number. So the Black mortality rate, 26.4 times higher than the white mortality rate. In the US, it's only 8. And I say only, that is still a huge difference. But in some of the cities, it's much lower. And then finally, I just wanted to show the opioid-related mortality rates. Clearly, some cities like Baltimore are having a huge problem. It's an epidemic there where there's 49 deaths per 100,000. That's almost 5 times higher than it is for the US. Some cities aren't struggling with this nearly as much. You can see Chicago up there with 15 per 100,000. What's particularly interesting about opioid-related mortality is that the Black-white difference is not so clear, it's not so consistent. So the cities at the top that include Chicago, they have a higher mortality rate from opioids than the white rate. The cities in blue have a higher white mortality rate compared to the Black rate. These are absolute differences here. So you can see in the United States as a whole, the white population tends to have a higher death rate from opioids than the Black population, but that's not true for all cities. What's also interesting is this number is changing, where a lot of cities originally had a higher white rate and now are flipping to having a higher Black rate. And now we're gonna pivot a little bit, and Fernando is gonna talk more about the why, helping us think about why we might see these differences between cities and between races.
Great, thanks very much, Maureen. And indeed, thanks to the IOMC for hosting us today and helping us celebrate the launch of the book. Maureen, before we say anything else, I always want to appreciate your leadership and vision for this project. And it really was a pleasure to work with you on this and this remarkable team, right, with Abigail Silva and many, many others who we listed earlier on. So it definitely is a team effort. And I think it shows in the work. There's a lot of data that we've processed, a lot of really important messages that come through. And I'm really thrilled to be here to discuss some of those themes with you all today. I don't know how everyone feels, but seeing these descriptive results, there's both an element of anger, right, about the injustice that's portrayed in the data, but there's also an element of hope, right, in that we tend to think of health inequities as deeply entrenched, monolithic problems, and they are deeply entrenched, right? They're rooted in our history and our politics, our economics, but they vary from place to place and they vary across time. And that for me is a source of hope, right? Because if we can identify those patterns, we can change them, right? There's the potential for all of our cities to become fairer and more equal places. And I think the data give us a hint of that hope. And I grab hold onto that. Next slide, please. Early on in the book, and here I'll show it so you can see that it's an actual physical book. Early on in the book, we dive through some of the history of different ways of thinking and approaching racialized inequities in the United States. And in chapter 2, we look at some theories, right, that have developed both in medicine and in public health and in related fields to try to understand, like, how do these data come to be, right? as Maureen mentioned, they're not natural. They are produced, right? They're produced by different elements of structural violence, political and social arrangements that harm populations. A big branch of the field has really focused on medical and lifestyle explanations, right? Where health is a personal responsibility, where we take an individualistic behavioral perspective. We find great limitations in medical. So I'm getting some echo. Oh, we find great limitations in seeing health as purely a personal responsibility, right? It diminishes, it pushes aside the structural and social determinants of health inequities, which I think are really, really vital. So we explore the medical and lifestyle traditions and explanations in chapter 2, and then we contrast them with different frameworks offered by Nancy Krieger and many others in social epidemiology to look at the psychosocial tradition, where the focus is on the experience of inequality. Here we have elements of the weathering framework, of allostatic load, of different models that try to explain what it is about inequality that literally gets under our skin to affect bodily systems. And then we also lean quite a lot on what Nancy Krieger calls the social political tradition, which is about naming structural drivers, deep-rooted structural systems that then flow, right, to eventually harm individual bodies. Next slide, please. This for me is very important framing as we try to look at the data and try to understand what's happening. You must always remember that the sociology, the history, the economics, the graphs, the charts, the regressions all land with great violence upon the body. And that's at the end result of all of our models, right? It's not abstract math, it's the living experience of individuals, of families, and communities. And next. Yeah. And a lot of this second half of the book in particular is influenced by the great work of, and thinking of Dr. Linda Ray Murray, a friend and colleague to many of us. In 2011, when she was the American Public Health Association president, she gave these remarks at our conference. We know that health is determined by, not influenced by, determined by social conditions. That is why social, economic, political, educational inequalities produce health inequalities. So that was 2011. Here we are roughly 10 years, and we have the data to kind of illustrate Dr. Murray's point. And we're going to look at the dual nature of inequality, the inequality that we have in our economics and the inequality that we have in our population health. We look through several frameworks. This one has gained a lot of attention, and I think many of you are familiar with it, from the World Health Organization and the Commission on the Social Determinants of Health. We found it very, very helpful. Right? On the far right, you have the impact on equity and health and well-being, and then different levels of causal factors. The social determinants of health, which have gained a lot of attention, but then very, very critically, the structural determinants of health inequities, right? Bringing in big macro level issues like governance, macroeconomic policies, social policies, including land, labor, market, housing, and land policies, and public policies writ large. That, I think, is our kind of our landscape, right? If we're really going to tackle health inequities in this country, we really need to understand the flow of these effects and document them with data and track them over time. In chapter 2, we contrast this framework, which we find a lot of value in, with this one here, which maybe isn't as familiar. This one comes from David Coburn, a sociologist at the University of Toronto. Notice that it does not have a traditional medical focus at all. Right? Individual behavior is not part of this framework. Health and well-being is still the outcome. But what's really important about this framework is it identifies factors and issues like income inequality, poverty, all the stuff that we describe as social determinants of health, right? Working conditions, education, healthcare, housing, transportation. But it recognizes that those things are both the causes of health and well-being, but they're also the consequences of other things, right? Degrees of welfare regimes, the degrees to which we rely on market mechanisms to distribute basic goods and services in population. And those are influenced by politics, the power of capital, neoliberal ideology, and other big issues that medicine and public health have traditionally not engaged in. Next slide, please. Eventually, we landed on this framework, and a version of this was then adapted and modified and kind of extended in the American Medical Association Strategic Plan for Racial Justice and Health Equity. This framework we find great value in. Our data are very much downstream, right? We're looking at mortality data. We're looking at it with a new way, with a new lens, trying to identify and quantify inequities. But we're mindful that we're really interested in the upstream root causes, both the living conditions and characteristics of communities, but also the far upstream, right? The institutional inequities, what in this graph calls the social inequities, and what we might refer to as the systems of power and oppression, right? That structure opportunity in this country. Next slide. Yeah. So we're looking at mortality indicators, but we're really telling the story of structural racism and the toll that structural racism levies on populations as expressed in health indicators. Next slide. So first, an important word of caution. There is no easy answer. There is no magical regression equation that I or anyone else will ever produce. There's no one variable in a regression model that's going to explain all of the variability across our cities. But I think we're painting a pretty convincing picture or some of the big building blocks in the data. Next slide. Yeah. Our strategy was simple, but I think very powerful, right? We don't have any very advanced regression models. We're staying very, very close to description, but we're looking for relationships. We're looking for associations. We started with two cornerstone variables, level of poverty and average levels of household income, measures of income inequality, measures of racial segregation, and we also accounted for population size and racial composition. Next slide. First, I want to acknowledge the huge variability that exists across our big cities. They're all big cities, but they're very different as well. Just in terms of population, right? New York City at over 8 million people is very different than the smaller of the largest cities with a population of just over 500,000. Poverty rates differ dramatically. The average poverty rate across the 30 cities is 21%, and it varies from 12 to 39. Likewise, median household income and percentage with a high school diploma. The cities also vary significantly in terms of composition, segregation, income inequality, and all of these other indicators that we're using as our main structural roots. I think in the interest of time, I'm going to go to the next slide, but you can look at these in a lot more detail in the book itself. We took a very systematic approach, looking at each of our outcomes, all-cause mortality, life expectancy, years of life lost, and then eventually the cause-specific findings as well. And we looked at it very systematically, very carefully in terms of its association with each of our independent variables or our root causes. I'll illustrate a couple in the next slide with some scatter plots, which I think are quite interesting. This one is not a surprise. This is probably what you expect. Along the y-axis, you have the total all-cause mortality rate, right? The higher that number, the more people who are dying every year per 100,000. Along the x-axis, along the bottom, you have a very important measure of income inequality, the index of concentration at the extremes. Again, this one is not the surprising result. This is the one that we probably expected to find, even though it is an injustice in and of itself. Cities with higher concentrations of poverty, like Detroit, are the cities with the highest levels of all-cause mortality. Cities with the highest concentrations of affluence, where income is being pulled up, have the lowest overall levels of mortality. So San Francisco and San Jose slope downward. One more click. Yeah. Now this slide, I think, is the interesting twist and one of the interesting messages that emerges from the data. We have the same variable along the x, that income of concentration at the extremes, but now we're not correlating with the overall mortality rate. We're looking at the relationship with the rate difference. So the larger the number, the larger the gap between Black and white people in terms of all-cause mortality. Here we're showing an association that's positive. So as the index of concentration at the extremes increases, as the top 1% pulls further and further away, we have larger and larger differences between Black and white people in terms of our mortality rates. Right? This for me is profound. It's the relationship, right? It's the dual nature of inequality, the deep link between our economic inequality and our epidemiological inequality, the economics and life expectancy. Similar story here with the Gini coefficient, another popular measure of income inequality. Higher levels of inequality are associated with higher levels of Black-white life expectancy differences. And next slide. And again, with cancer rate differences as well. There is admittedly lots of noise, right? And this was associated with my word of caution at the beginning. But there's no perfect answer that explains all of the variability across the United States. And we didn't expect that there would be. But there's patterns. And I think there's elements of hope as well here, that even within high levels of inequality, higher levels of Gini values in that slide, you can still have a lot of variability, right? So there's a lot of things that can happen among health systems, among welfare systems, to make populations healthier and more equal. In terms of local policies, I'll go through this fairly quickly, but we did look at local policies, including inclusionary zoning regulations that boost affordable housing stock, anti-tobacco policies, universal access to kindergarten, and so on. And as you might expect, the cities with gold stars that have better, more progressive policies tended to have lower mortality rates, Chicago being an exception. The next slide. But even among the gold star cities that are doing all the right things, apparently, we still have huge and significant differences between Black and white all-cause mortality, right? So notice the two boxes for the gold star cities in particular. There's inequities across the policy spectrum. This, of course, is correlation, not causation, and we need data like this over time, right, as routinely tracked to really evaluate progress in the long run. Next slide. Very quickly, then I'll finish up with just a couple ideas that emerge in part 4 of the book, From Data to Action. There's a huge history at play, many commissions, task forces, systems at the federal level and also at the local level that this connects with. Next slide. But this is the fundamental challenge that Maureen mentioned before. This number is not substantially different. In fact, it's a little bit higher now than it was 20 years ago. Perhaps we have a more nuanced story to tell, though. Notice that here it's the healthcare gap kills. And it's true, there's huge and inequitable access to health insurance and healthcare in this country. But healthcare is of course, part of a larger mosaic that we're understanding, right? The root causes of structural racism and other forces of oppression that land in housing and transportation and food security. So the picture is admittedly more complex now than it was 20 years ago. The healthcare gap is a huge piece of it, but it doesn't entirely explain why our zip code predicts our life expectancy with devastating accuracy in this country. Next slide. Yeah, so in chapter 7, 8, and 9, I think there's some fantastic material from a remarkable set of colleagues. Abigail Silva et al. Looking at a social justice framework, the idea of praxis to achieve health equity. The team at Sinai looking at solution-focused communication and how to make data come alive in a meaningful and practical way for all communities. And then the book ends with a remarkable case study of Westside United. And I know lots of people on this call are actively engaged and supporting those efforts. And so we finish much like we started with Steve Whitman, right? We have to regard this problem as it was a problem in our family, which it is, and we have to fight like hell to change it. So again, I hope this book is of value to you, and if, like me, maybe it fills you with some degree of anger and some degree of hope. We have done a good job. So thanks again for your attention, and we look forward to the conversation and questions.
Well, thank you both for really distilling very well the important points from your book. So you guys did a phenomenal job with that. I have a couple of questions. There's one in the chat. Have you all given any thought to, because you listed a number of initiatives that have been put in place to try to deal with these gaps. People talk a lot about Medicaid expansion, and here in Illinois, we did that, and Chicago was a big market for that. We've got several national plans here. We have County Care has a large health plan. Did you guys give any thought to Medicaid expansion and why it looks like, if I look at your map, several of those places are places where they expanded Medicaid, but is it because of the timing perhaps of the data pool that you did, or what could that be? Well, we expanded access theoretically, but we didn't get any sort of results from that. So thoughts there?
Yeah, great, thank you. It's a very important question. And I think part of the answer is about time, right? The needing to invest in local data to be able to track inequities and how they change as a result of policies is something that we don't have a very strong infrastructure for in this country. So even just documenting the inequities, the rate differences, the rate ratios, and the excess deaths at the city level, it was a new step and something we haven't had before. So I think with these kind of metrics now, we can better evaluate the passing or the rejection of policies like expanding Medicaid. My gut response, though, my gut feeling is that it's not going to fully address. So remember that what causes health framework from the Bay Area Regional Health Initiative. Healthcare is a huge part of it, but it's not the only part of it. Right? We need better and more equitable access to transportation, to food security, to employment security, financial security, all of these social and structural drivers. Healthcare is a huge part of it, but until we really tackle those further upstream issues, we're still going to have, unfortunately, I think we're still going to have many of the inequities that we see in the data.
Well, just to put some data to it, financial data. So Illinois spends over like $20+ billion on Medicaid every year. So that's those are numbers we're talking about, and a good chunk of that is in Chicago. So the question is, why, if you're spending billions, like, are we spending it wrong, right? Like, what's the answer? Because we're talking about billions. Another question, and we got two in the chat, but sort of, you talked a little bit about city level data and why it's important. Anything else you can elucidate there for us of why being able to look at the city level data is important, Maureen?
Sure. For one thing, a good part of our country lives in urban areas, about 80%, and that number is increasing and higher among communities of color. And also, when the smallest area of analysis you have is counties, it really masks a lot of the variation. So we can imagine this living in Cook County, that Chicago is different than the areas that surround it. Communities like Western Springs, for example, or there are all kinds of variation across that big geographic area. Empirically, a team from City Health Dashboard just looked at this, not only in Chicago, but in a lot of big cities. And they found, in fact, the outcomes, health outcomes and health risk factors are really different if you measure it by the city or by the county that city is included within. So it's really important for cities, if they're trying to make evidence-based decisions or target and tailor policies and interventions, to have data for their jurisdiction. And there's just not a systematic source that routinely provides this, nor can a lot of city health departments afford the manpower to do the analyses that we've done over the last few years.
Thank you, Maureen. Fernando, this is a book primarily about public health and about social epidemiology, but it also is about, social change. When you talked about radical statistics, can you speak to how you think physicians or health systems might engage with this work?
Great, thank you. That's something that we're thinking a lot about at the AMA, how we can make these data as practical and useful as possible to physicians and health systems. It's a big part of the work that we're doing at the Center for Health Equity. It's in our vision statement. We talk about a nation where physicians are equipped with a consciousness, tools, and resources to confront inequities, to dismantle white supremacy, racism, and other forms of exclusion and structured oppression. So what's the role of data in that? What's the role of local data in that? If you consider community health needs assessments, they've come a long way in many places across the United States, but there's no standard methodology, and only a fraction of CHNAs coming out of hospitals routinely use metrics like these, right? Of rate differences, rate ratios, excess deaths. I would love to see some of these metrics, some of these equity metrics, routinely used in community health needs assessments, and across communications coming out of public health departments and out of healthcare broadly defined. I think we're seeing a huge movement. There are people like Rishi Manchanda and others at Health Begins that call for an upstreamist movement, right, where more and more physicians recognize and address the structural root causes of health inequities. And I'm hoping that this book will connect with that.
Great. So we've got a few questions. Let's try to get through some of them, guys. We have about 10 minutes here. Is there any evidence, have you guys thought about this yet? This may be in your next iteration. Is there any evidence that providing a universal base income will make a difference in the Black-white life expectancy gap? Who's got that one, Maureen or Fernando?
I do not know the answer to that. I think a lot of these questions that we're seeing are what we're looking at next. because it does bring this question of why are some cities having this big gap, and why don't those characteristics that we looked at explain it better? So one thing we're going to be doing is looking at those 30 cities and saying, what kind of policies do they have in place? Do they have health equity plans in place? Do they have specific offices or departments related to equity, similar to like a health and all policies type approach where you're looking at equity in all policies? So I don't know the answer, but maybe someone else here does.
But it's the right question to ask, right? Like it's the right question. Will any of these policies or initiatives not just improve the health of individual people who are involved in the plan, but will it fundamentally change the landscape of that place, or that community, or that city? Yeah, we don't know the answer to it, but I think it's the right question to ask. And if we do our job right, we can set up data systems to then explore that in the future.
Yeah, and Fernando, as you guys do that, you look at the data on kind of where you live, zip code data. I mean, a lot of that's are layers of public policy that take a community to where that community is. So a universal basic income won't overcome necessarily that, right? Because like when Target or other stores look at where they're going to place the store, they look at the census tract data and their income and whatnot, and they make decisions, right? So on the South Side where I lived for 23 years, they closed 3 Targets, all within like a small amount of time, but they left the ones on the North Side open. So these sort of, will universal basic income change that? I think those are the kind of questions we have to begin to ask. This is a question. Is there a website that aggregates links to the various public health initiatives over the past 30 to 40 years? I know you all had a great slide on that. It was pretty full of information. Is that in your book? Is it posted anywhere else, a website like that that has those kind of, that kind of information on it?
If there is one, I could not find it. It took a lot of work to piece together that chart that's in the book. And every time I read a new article, I'd hear one more and I'd go and find it. So that would be a great resource, but I don't know of it.
The other thing too, as you guys build out that kind of slide is, don't forget big policy changes like Medicaid expansion, like President Biden is saying he's going to increase, millions and millions of dollars of care to home-based care, or keeping people in the home versus nursing homes. Those have huge impacts. But where does all that money go? I think someone needs to be asking those questions. If those communities indeed are getting those, are they going to close gaps that cause a lot of stress to those communities? You got a good number of questions here. Here's another one. I might just jump and answer this because I think the person is answering the question themselves, which is about the opioid slide. Said that's usually the opposite of what you see with white people, with the sort of different disparities that white people have more. Is it that opioids are more prescribed to white people than Black people? So let me just answer this as a Black physician who actually worked in San Francisco. I want to share this with you. When it was happening to Black people, opioid crisis, it was heroin addiction. But when it became something that was prescribed, then now it's opioid addiction, and we've got all kind of new rules and laws about it. And we've, in a sense, decriminalized it. We've given Narcan to be injected in many municipalities, right? Where we never did that for Black people when it was heroin addiction. So guys, that in itself is a racial thing. What is that? That's discrimination. That's for one population it's a medical issue, and for Black people it was an addiction, put you in jail. So that is an interesting disparity. So yes, I think now treatment is more acceptable. If you look at some of the venture and private equity things that are going on, there are treatment centers popping up all over the US that have already popped up that are leveraging federal funding, right, for treatment to build out multi-billion-dollar actually entities that offer treatment. So and then access to treatment for Black people in those communities is way less available. And you can see it in the Medicaid data. People circle in and out, getting 3 days of treatment, and then nothing, to nowhere. Then they circle back in again. So people are billing for something where there's really no accountability for treatment in those communities. And guys, this is you could do a whole book on that issue. Let me go to the chat because some of those popped up before the Q&A. So bear with me. You guys see those questions. Let's see. There's one from Frank and Sally. I can't see your last name. Correlation versus causation. Would education level correlate similarly and be a part of causation? Oh, this is a good epidemiologist sort of question. Either one of you guys want to take that?
Yeah, I'd be happy to. The data on education produced actually very little. So we did look at high school graduation rates, and there are other ways of looking, of course, at educational attainment at the city level. But we had data on high school graduation. It did very little to explain the city to city variability and some of our inequity measures.
Yeah.
Really, the bulk of the explanatory power fell on our measures of income inequality and racial segregation. That's not to say that education isn't part of the story, but it didn't come through in these analyses.
Now, you all brought this up in your presentation. It's a question from Kim Irwin. How do we get health systems to develop, share, and take responsibility for community health level health measures? For example, what is the blood pressure of Boston? You talked about the community health needs assessments and how they were used or not being used, how they could be used more effectively. Any thoughts on how you could get health systems to kind of take responsibility for those measures? Any thoughts there? I mean, that's probably a little bit more radical statistics. I don't know, Dr. De Maio, what do you think about that?
Yeah, no, this is a huge challenge, but I think there's evidence of that happening across the country with the Healthcare Anchor Network, collaboratives like Westside United, where health systems are taking a far more active and engaged role, sharing power with communities, bringing resources to bear, and tracking things like life expectancy inequities. The blood pressure measurements and the more proximal risk factors I think are also key, of course, to measure. But if we can get clarity on the outcomes, on inequities, and if we can get more clarity on the structural drivers that's generating those outcomes in each community, in each city, we'll go a long way towards a more equitable country.
I just want to add to that, live on the South Side and look at the data, you can see where we got, heavy morbidity, mortality from chronic kidney disease, et cetera, where hypertension is an upstream driver for all these illnesses, many of them, but there are no campaigns regarding blood pressure that you can see, right? So we need more like awareness, like the social kind of engagement awareness that's culturally kind of sound and centered. There's really been little to nothing in the last decade, guys, that I've seen invested in talking about things like hypertension. Maybe people feel we get tired of talking about it, but breast cancer maybe gets more of a kick, right? We hear more about getting a mammogram or anything about, hey, you need to get your blood pressure checked, and here are all the places you can go to do it. So, I think there's a lot of low-hanging fruit that could be pursued by systems and others who care. Here's a question that actually jumps on this. Says, do you show, this is from Daniel Bassill, B-A-S-S-I-L-L, do you show strategies that might motivate more people living in affluent areas to care enough to be more active in pursuing solutions? Either one of you guys, any thoughts there? I can't hear either one of you. I don't know if that's me, but Maureen, you're on mute, I know. You could say pass.
No. We don't have the answer to it, but I think it's something that's, of course, it's vital, right? Like how we communicate these data in a way that captures attention by people who don't think it's their responsibility or their problem. And I think that points to our relative failure as a community, as a healthcare community, to even explain life expectancy and explain life expectancy differences. People are not generally aware of the level of inequality in our populations, and that affects our neighbors, right? Our families and our neighbors. Maybe COVID will change that because people are perhaps a little bit more tuned into outcomes and inequities. But going from there to looking at differences in kidney disease and lung cancer, heart disease, that's, I think, our responsibility in healthcare across the board.
So probably the last question we can take is 1258. This gets at, this by Anonymous, basically talking about implicit bias, kind of attitudes towards health care to Black people, playing a role in the data or access to quality health and systems in the US. Any thoughts there, guys, about implicit bias that you come across that or consider that in this book?
Clearly that's important in a healthcare setting and issues related to access to care. In the book, we dealt more with the structural facets of racism, which is, if you think about the iceberg image, if you've seen that, where there's explicit bias, and that's a real tip, and then interpersonal bias is important, but it's really the structural aspects of systematic differences and discrimination through the systems and institutions themselves, not the providers that we're focused on here.
Do you see the last question? Dr. Jones had a question about studies that correlate attitudes toward healthcare and providers by Blacks and their access to quality providers. Is there studies or data that map providers and hospital systems to those bad outcomes or good outcomes? Any thoughts there, guys, before we?
I'm not aware of any.
Okay. Well, it looks like you all have lots and lots of opportunities for this next book. We're looking forward to 2.0. Look, Maureen, we're excited that, that really Dr. Whitman's work lives on in a way to this sort of, really 4.0 iteration. This is what Steve would want us to do, is to push for radical change using, radical statistics. Dr. Maio, I love that term, but also just good old-fashioned epidemiology and digging deeper and trying to put together some results, data that we can all ingest and hopefully react to and make a move that's positive for these communities. Many of them are our communities. So with that, I want to wrap this up. We're a minute late, but this was really awesome, very interesting. Please go check out the book. I'll just talk it for them. Go buy it. It's on Amazon. But bring it to the classroom. I'm going to get it, guys, for holiday reading for my family. We push hard in the Whitaker family. So super psyched. I want to thank everyone for being on today. And we look forward to continue to support this work, to learn from it. And maybe you guys will come back again soon. Thank you so much. Have a great evening, everyone. Great afternoon.
Thanks for having us.
Absolutely.